as is befitting, I should congratulate everybody on this World Malaria Day, in the sense that it brings back into our cognizance the problem of malaria, which at NIMR should be there all the time and all year. Yes, indeed. This is an especially interesting year for all of us and for Malaria Day also, because we've just sort of, I would say, partly recovered from the pandemic that we had recently, and the world has been plunged into another chaos, which is the ongoing war in Europe or Eurasia. And you know very well that that will also have direct and indirect effects on public health and also on malaria sooner or later, because supply chains are affected severely, funding is affected severely, the collaboration between countries is affected severely, and crosstalk between scientists is also affected severely when you have a situation where there is tension between countries, and when the world is from a unipolar mode, which was not good anyway. We will go back probably to a bipolar mode, but a lot of aggression. So these are not the best of times, but you know, for malaria, these are also troubling in other ways, because the malaria report, the last malaria report, clearly suggested that the number of deaths and cases has in fact gone up in the past year, partly due to COVID and partly due to other reasons. And we are doing an analysis, but I should tell you that there's about already a $3 billion deficit in malaria control worldwide. $3 billion, so about $6.5 billion is what. Okay, $6.5 billion is the running cost for a reasonable malaria elimination programs, control and elimination, and only about $3 billion are invested currently. And it is estimated that to achieve elimination worldwide, we need about $12 to $15 billion. So that's a five-fold increase from current levels. And that's not going to be easy in the current economic situation that the world finds itself in. And I will not be surprised if malaria program is partly or wholly derailed in many regions in the world. But as a malaria research organization, our duty is to keep providing new insights from research that can help the program control malaria. And I think in that context, we are mostly on track. We've launched, as you know, many new programs, some of which will be detailed today by MERA, which are specifically targeting malaria elimination, but also we've started several themes of research which may not bear fruition in the next 2 to 3 years, but would certainly bear fruition in the 5 to 10 year window. And I think that's what's really important. We need to keep investing in research, keep investing in human capital, and keep investing resources in infrastructure to be future ready for malaria. And I hope you will all agree that at least from NIMR's part, we are all on track, or mostly on track, and if not, then we'll be happy to bend course in that regard. As we are running a little late, I'll be brief. It's my great pleasure to introduce the speaker today, who's been my friend and collaborator for just about 2 years since I met him first. And it's been really a pleasure dealing with him and understanding epidemiology and other infectious diseases on which he works, including he works on mental disorders. He is a polymath. He understands everything to do with public health and specifically operational research. He's been interested in MERA. He's done a lot of work in MERA. And he's been a co-author or driver of many of our research papers where he's really done some very insightful work on infectious disease and in malaria and in COVID. So it's my pleasure to invite you, Dr. Malhotra, here. You've already been introduced to most of the scientists who are here physically, and they will be introduced to you during the course of this lecture. I'll pass the mic on to you now.
Thank you for that kind introduction, Amit sir and Dr. Sachin. It's really an honor and pleasure to be here among all of you. And I think last 2 years that this relationship that I have developed, through Amit sir, Dr. Manju, Dr. Sachin, in several of initiatives, it's really very heartening to see the way things are being taken up under your leadership, sir. And a lot of, projects and the research which is being driven by this institute is remarkable. So it's very fortunate that I am here on a very auspicious day and addressing all of you. Well, why I took the topic that I am going to speak today, I think this is very relevant, especially so when we know that there are many interventions that exist now for malaria control and elimination. But just to think and ponder how much have we achieved and what's the coverage of these interventions. So are we really having the best coverage of these interventions to all people that need them? And if we answer that question, from within ourselves and introspect, I think there's a lot that requires to be done. So there is a lot of scope for bringing improvements, for strengthening the programmatic activities, and therefore we need to be aware. Sorry, we need to be aware of now this kind of research. The art and science of implementation research, which I think requires a lot of awareness generation also. So people don't know that there is something like this, but all our programs and all those people who are there associated with public health activities, should know that we need to constantly be working towards betterment, and improvements can only be brought if we also generate sufficient evidence what's working on ground. So therefore, in evidence-based decision-making era, I think implementation research is very, very important. Can I have my slides, please? And can I have the slides also? Thanks. Okay. Now let's also think what constitutes health system. I believe there are PhD scholars also here. They are attending. Okay, but I don't think so that we'll be able to connect with them through this hybrid modality. Anyways, so what is health system and what the blocks of the health system are? It essentially has human resources. It is constituted by variety of logistics, supplies, finances, governance, institutional mechanisms, and in day-to-day operations. When we talk about, we think about having outpatient services, inpatient services, pharmacies, a lot of goods being produced there, and essentially, I mean, one of the critical stake is that of community that we are addressing the needs for. So how are outreach services being provided, and the various human resources and the kind of workers that we have in our systems, be it ASHA workers or, ANMs, multipurpose workers, malaria workers, and things like that. So all of this constitutes health system. And in each of these dimensions, there could be issues that we need to know and be cognizant of. Let's also think about when we have a particular intervention which is tested for its efficacy. Now let's consider there is an intervention, and COVID is one example, so I'll just relate this to COVID as well. Suppose we have a vaccine, for COVID, for protection of SARS-CoV-2. We do randomized clinical trials to see, how much is the efficacy of these vaccines that we have, be it Covaxin or Covishield in the Indian context. So they are being tested by phase 3 clinical trials. But when we test these, potential tools, which can have importance and which can actually produce some effect, which are worthy of producing effect, we take the best scenarios and we get the best possible patients whom we give these new interventions. So we call whatsoever the effect they produce is the best effect that they can produce in an ideal setup. When these newer interventions, efficacious tools get introduced into the real world, there are many more things that come into play. So for example, when we talk about COVID vaccine, so in real world, there'll be people with diabetes, people with hypertension, people with cancers, people with different, immunocompromised states. They will also receive the vaccine, but not necessarily they will get the same result which we got in the best profile of patients. So what we get in them, the protection by the virus is going to be effectiveness. So the initial interventions, whenever or tools, when they get introduced, we get some efficacy and effectiveness parameters. And based on this, we decide that they are worthy of being introduced into our larger health systems or intervention packages, and we roll these interventions. So they undergo the scrutiny of pilot testing, the feasibility testing, but then when we really scale them to a larger, geographic reach, we see that we don't achieve that much success. And we witness failures. The same interventions that produced very good effects in the best and also in the real world scenario, but imagine you have a forest geography and you want to do malaria interventions there, which is a high burden. Maybe an ASHA is not there, or there is nobody to man the center there. People get affected with fever. People die also because of malaria, right? So the interventions do not reach the last mile where they are needed the most. And this makes the scenario very, changed. And therefore, we need to understand that when we talk about this efficacious and effective interventions, there are many layers that come in between. And then the factors like accessibility, reach, the human resources that are delivering the interventions, how competent are they, how motivated are they, when they deliver, say, drugs, do they counsel properly? Whatsoever they want to do, is it being really taken up by the patients? Well, if we want to give them 14-day regime, do they really take 14-day regime? So all of these factors will really come into play, and all ultimately results in affecting the impact, the larger impact of the interventions. So therefore, it's important to understand in public health and in all the program activities, is not moving. In all the program activities, the context plays a very important role. And when we talk about the context, let's see this example. Now, there are two circles here that you see. Imagine there is one medical officer who is working in one health center, and there is another medical officer working in another, health center. And the surrounding circles are the other stakeholders, maybe CMO, SMO, AIIMS, ASHAs, and so many other stakeholders. Now, what can you make out just by seeing this? And I want some volunteer to say, just by looking to this picture, what is the impression that we are gaining out of it? And you can use the mic. There is a mic there. And those who are at least here should say, what is that you are taking out of this slide? What is the interpretation and what impression that is really tell you by looking to this?
First picture, medical officer has to little efforts, but in second picture you can see medical officer has to play very great efforts to implement the same.
Okay.
Maybe.
Okay, any other interpretation? Anybody would like to say more? I mean, it could be anything. We don't have to be really right, but I mean, one judgment that what one gets out of this circles.
The stakeholders have a bigger role in the scenario.
Yeah, exactly. Thanks. So it's both the circles actually, which are there in orange are of same size, but they're looking different. So this is a psychological kind of a situation wherein there is an influence in the first figure of the outer stakeholders, and they really are making an influence on the inner circle. Whereas in the second picture, the other stakeholders which are surrounding, that person who is driving the place, they are not affecting the second person. So what I want to say, by this is that the people work in context, people work under the influence of many influencers. And how those influencers makes a big change in delivery of interventions, right? So this is very important when we have to understand the public health interventions. Why do they succeed at one place and they do not succeed in another place when we have a similar set of interventions? So there are many layers that we need to understand. So there's an inner setting and there is an outer setting. Imagine there is an intervention, the same diagnostic test to be done at different places. Okay, in one the tests are routinely happening. Just as a kind of corollary to this, just imagine you go to a vaccination center to get the vaccine. Okay, one place you get the vaccine so easily, another place you find the same vaccine. Maybe you land up in a different center for second dose or booster. You see the situation is different and probably you get more troubled. There, it's the same vaccine available at both the places, but actually the people who are manning that center makes a big change in making you comfortable to receive what you wanted to receive today. Right? So maybe the doctors are burdened there. The staff is not motivated. They consider this as a burden to them, and they are not interested in welcoming. They probably want less patients in a day rather than hundreds or 200s to be vaccinated in a day. This is another center who is very there's a jovial environment there. Everybody is in a happy state. If one is absent, the other takes care of the work, and there is sufficient task shifting. Cooperation, coordination, vaccine, stock in supply, timely, no stock outs. The COVID app is running very nicely. Another center you go, COVID app doesn't run. There are digital issues, net connectivity. Now, all of these influence the same vaccine getting delivered to different people, and the experiences of different people are going to be different. So this is the influence of layers in which our interventions are implemented. And these layers are very contextualized and they vary from one place to another place, from one institute to another institute. And all of this ultimately shape up the delivery of intervention. And therefore, what works in one situation or at one place may not be the strategy of implementation in another place. And therefore, the strategies may require a bit of tweaking what we recommend on a generic basis. And this is what we need to understand when we talk about implementation research. So we know what interventions are there. For many of the public health problems today, we know what are the interventions that are going to produce effects. But what we really do not know, how do we make them work to all the people who need them, right? And therefore, there is a sufficient gap which is there from no to do gap. And it is this gap which requires addressal, which requires innovation and which requires solutions. And that is what the implementation research is all about. It's a scientific study of scientific methods, ultimately to promote the systematic uptake of research findings and other evidence-based interventions with a goal to improvise the quality and also the effectiveness of health services and care. So we want our evidence-based interventions to get implemented in best possible scenario, and then it produces, the best results that it can achieve. So in practical terms, what implementation research focuses on, it focuses on identifying the common implementation problems, and all the public health programs will have implementation problems. There are going to be certain facilitators and there are going to be certain barriers. We need to understand these factors that promote the uptake of interventions and the factors that actually hinder the uptake. We need to find solutions to address these barriers, and then in practical ways, we want to find out how we can actually get them integrated and embedded in our larger health systems, and ultimately we want them to be scaled up, sustained, so that we do continue getting the results in a best possible way. So I think some kind of characteristics, this is very contextual. So when we talk about implementation research, this is very context specific. So what is true in Kerala may not be true in Bihar. What is true in Tamil Nadu may not be true in Uttar Pradesh. And we need to understand what is true in Chhattisgarh may not be true in Delhi. So we need to understand this is very context specific, and therefore you need to find context specific solutions. This is pragmatic. We need to understand this is real world. We are not talking about the best possible scenario. So you may not have at a health post the best doctor with best motivation. You have to work with limited resources, and whatsoever operational challenges you have to find solutions for them. It's real time. This research is multidisciplinary. It involves and engages a lot of stakeholders, and a lot of science streams are involved, be it epidemiology, be it social sciences, be it biostatistics, be it vector experts, be it economics and things like that. So there are a lot of people, and because it concerns the problems of programs, we need to understand that program managers are very critical here. People who are manning the field level operations, they are the best people to tell what the problems are, and also can tell you what could work and what will not work here. So it's important to have these teams in place, because when these synergies are going to work together, ultimately this research is going to be benefited. It focuses on processes. So activities are very important. So it's important to not just know the inputs what a program will receive, but it's also important how it is delivered. So is it that the online training is the solution for all our health workers? I mean, COVID has really given us the flavor that we can have hybrid programs, and it has its benefits. There's no denial from that fact that the connectivity is really enhanced. So, but is that the same level of mentoring required to an ASHA worker? Will it work? We need to think, right? So process. So I'm just giving you one example, that training activity could be one process, and the way to deliver that training program, there are multiple options that we have. And we need to think about what modalities we are going to fit into our program. And the methods are going to fit for purpose. It has to be relevant, and ultimately it needs to solve the agenda that we have in public health programs. So which policy is best to be introduced in a particular context? What is the best way to implement it? How can the target population be reached? So we are thinking about all difficult people to be reached. We want to address the inequities that we have in our program, be it gender inequity, be it economic, be it geographic.
There are several of these inequities, and how can we address them? What factors are going to really affect the implementation? And I think what is very, very key to understand is implementation research tries to find ways to adopt and adapt the program interventions, okay, that how best we can deliver them. And of course, they come with a cost, so one has to study the the cost factor and which is the best solution. And overall, we want all of these things to be scaled up. Now, just some pieces, what is not implementation research? All of us understand, the classical, case control, randomized control trials, which tells you about, the factors that relate to diseases and what could be the possible answers. So that traditional epidemiological research is not implementation research. Similarly, the efficacy research, finding out newer tools, is not implementation research. We are going beyond efficacy and effectiveness. No, the real utility of implementation research begins after we have established efficacy and effectiveness of interventions. It's basically the uptake of these effective interventions in the field settings. That is what we need to understand how best we can deliver these, right? M&E is not, in simple words, implementation research. M&E can tell you the problems, can find out how are we doing currently. But to solve those problems, you need to do something more beyond M&E. And then we have operations research also, which is purely a mathematical modeling-based technique. That also is not implementation research. So implementation research is really action research. It's a participative research. Often we want to test by doing it what produces results and things like that, right? Now, I'll give two examples in the country wherein, and many of you must be aware of this, so I'm just kind of reiterating. I'm not directly involved in this work, but then these are good pieces on Malaria Day to reflect upon. That country has tried different ways of strengthening the routine program delivery. And in process of strengthening, we have tried to measure whether we get the changes in outcomes. So I'll just make two case studies as an illustrative example. So one is the comprehensive case management in Odisha, and we all know that it's a high burden malaria state. So I mean, ICMR was also a party to this study in both the examples that I'm going to give. So way back in 2013, this study was initiated. It was a large program, multi-year program that implemented and assessed the impact of a repurposed and strengthened form of early detection and complete treatment. So these days also we talk a lot about asymptomatic malaria and detecting it. And so this was a quasi-experimental study. By quasi-experimental study, we mean that things were purposely chosen. They were not randomized. There were 4 districts that were there, in Odisha that were being chosen, and they range from a low, moderate to high hyper endemicity for malaria. Each of the district you had 2 blocks that were being, chosen. One in which they had the strengthened intervention delivery, which is marked as green, and one in blue, which was served as control. So they compared, there was some epidemiological basis as how they selected these, areas for implementation. Now, what it involved? It involved, training, capacity building, and supportive supervision. Often, supportive supervision is an element which is missed in the programs because of various reasons, but I think it's a very critical parameter for improving performances of our human resources. Then they mapped out, certain left out pockets, and they said that these are underserved areas and they require, additional providers so that they can, do service delivery. And then they had malaria cards being introduced to see, patients being given treatment and they completed it. There were more microscopy centers created. There were mechanisms for supportive supervision of these additional workers. They had mass screening and treatment. They had uninterrupted supply of drugs and also the diagnostics, and they enhanced and strengthened the surveillance, and they also had electronic health information systems to see and capture how things were going on. What I want you to also appreciate, and in public health, the interventions are complex. They're not simple. You see, there are eight points, and each point has many processes, right? So just appreciate that. That's why things are complicated here, because there are many players and many processes, and all of this can be right or wrong at some places. So it's a multi-year project with different phases. Started in 2009 and 12, and went. The actual phase was phase 2, 2013 to 2015. And then after the interventions were being matured, the delivery was matured, they also continued surveillance and the case finding and how it was basically being done. Now the hypothesis one was that your monthly blood examination rate and monthly parasite incidence is going to increase from this phase to phase 2 because of all of the 8 action points. And once we achieve some kind of success here, then this is going to decrease from this phase to this. So overall, the burden of malaria is going to be on the declining mode after an initial increase of picking up cases, and also you did mass testing and things like that. So they measured all of these things. So 2013, the overall 6.5% positivity was there, which was seen in the intervention block, which dropped down to 3.6%. Your patients getting complete treatment increased. They did difference in difference analysis and interrupted time series analysis. So some statistical tools to see whether these hypotheses were being met, and the plausibility testing was being done. And they found that in the phase 1, the monthly blood examination rate and the parasite incidence actually increased compared to the phase 1. And in the phase 3, they see a kind of, largely an unchanged or a slight decrease in monthly blood examination rate, but overall decline in the monthly parasite incidence. So there was data to back up that, yes, all of this has potential to work. So it improved early detection of malaria. It improved, the treatment service uptake. The case incidence was affected, and then they were being taken up for scale also. There were differences in these districts. I'm not saying block-wise. There were a lot of variations that existed, but the pooled analysis was this. So this is one case wherein they implemented a lot of processes in a strengthened fashion, and then see whether it makes a dent in the program delivery and reduction of malaria occurrence, and it did, but it was a lot of effort, let me tell you. The another case study on vector control, which was done in another endemic region in Madhya Pradesh, in Mandla district, wherein they focused on operations of indoor residual spraying and NIMR. And what they introduced was monitoring and supervision. And again, let me tell you, these are very critical processes which are often ignored. So they are very important parameters, and they actually focused on this. So this was in another high endemic place. They focused on indoor residual spraying. So they had the synthetic pyrethroid alpha-cypermethrin as part of IRS. So they had these campaigns wherever they were being needed for household spraying activities. They focused on supervision. So there was checklists that were being devised, and these checklists, somebody was appointed as supervisor within the system who had to be there to see what these teams are doing, spraying teams. And there's a big difference, when somebody is watching you, you really take your job seriously. When somebody is not watching you on a continuous basis, हम काम कर रहे हैं या नहीं कर रहे हैं कोई फर्क नहीं पड़ता है. But अगर हमें पता है कि हमारे पे नजर रखी जा रही है, and somebody is going to support us in case we are not doing job perfectly. It's not that there are going to be punitive actions. Agar punitive actions honge, to it has a near problem, but supervision has to be supportive. So that if one is not able to do the task proficiently and competently, the supervisors in the system try to correct your faults rather than making you more done. Okay, so they did and invested in these. They focused on quality and technique. Monitoring really improved in the intervention years. The post-spraying observations were also being done in the households. Community awareness was being checked. Use of these AIIMS were being monitored. And really, there was a change in the process indicators and the impact indicators. Improvements in quality occurred. Coverage of sprayed households, improved. The adverse effects were reduced. Community awareness improved. So all of these, ultimately said that this is possible. This is possible, but this requires extra efforts. And probably when we are implementing our programs, we don't bother to do these components, and therefore in routine, the things get diluted, right? So this also, proved that yes, there is a lot of strengthening in these vector control processes. It could be done. Even if we have to do IDC and VCC, it could be done in a different way, and people can be made aware of what is going on. So just to sum up, from these case studies, whenever an intervention or intervention tools, pass the efficacy and effectiveness, evidences, the next things are how do we really, make them implementable. So we require implementation trials in different settings. And let me tell you, it takes 10 to 20 years before really we get evidence from different settings that what one can really be confident of, being delivered in the most pragmatic fashion. And we study things in the real world. Context is important. Barriers and facilitators, and improvising and working on that is something. This will require a lot of mixed methods. So this is not method specific. Methods are decided based on what you want to do. So whether it's quantitative methods or it's qualitative methods, this will have a lot of theories, hypotheses. It will have frameworks, what you want to do and how you are going to do. We have a lot of frameworks. Let me tell you, implementation science is a very evolving field. There is a lot which is known, but there is still which is unknown. And as we are doing more things, scientists and researchers are getting more, experiences in doing these things. There are many, frameworks. One of them which is used is CFIR, and CFIR does appreciate, that there is a role played by layers. So there is an inner setting, there is an outer setting. So if this is in an institute, the inner setting is basically this institute itself, but the outer setting is going to be the influence of larger ICMR. And you see that, there are a lot of factors. And then the processes are something that we require, an in-depth deliberation. Stakeholders are involved. So this is an unadapted intervention, and you are playing with this adaptation of intervention. There are 39 constructs in this framework. It's quite complicated, but it tells you a lot of detailing. It requires detailing, and then you get, some clarity how to do this. We also have another very commonly used framework in our, research works. That's Reaim Framework, which basically talks about reach. It talks about efficacy and effectiveness. As I mentioned, adoption and adaptation is important. How are we going to implement? How are we going to get our strategies implemented at different levels? And then how are we going to sustain the implementation delivery? So, one important message as a takeaway, before I, get closer to the end, is that we We just don't have outcomes and impact as final parameters of study in implementation research. We also think about our implementation outcomes. And when we say implementation outcomes, you have parameters like whether the intervention is acceptable, is it appropriate? If you're working in a tribal area, many things are not feasible. You need to think differently to address the needs of tribal people, right? So are they going to be adopted? Is it feasible? You want to study different processes, and are they really going to be taken up in good sense? What are the costs involved? How are you going to sustain the coverage and reach of these interventions? So these are all important implementation outcome parameters, and these are also important things that we study in implementation research, apart from doing the routine business of studying the final results or the impact results. Well, no research is without ethics in today's environment. You have to have, the ethical principles in your place, and the principles of doing no harm always have to be met. It requires a lot of co-creation and engagement with stakeholders on ground. So you need to have their consent. Multiple gatekeepers are going to be there. You need to win their confidence to really see the solutions. Often now what is said is that when you are working on theories of change, how are you going to bring the change? This itself is a co-creation and stakeholder engagement process. So you need to get them on board to see what can work and what cannot work. As I mentioned, this is a participatory research. It works on bringing improvements on quality and effectiveness, requires mixed methods. It's quite complicated because the processes are complicated when you think about the real world challenges. But it requires an attention from the people who are managing the programs, and requires an investment. You require teams to be together, and their synergies have to be put on place so that they work together to achieve the gains that they are envisaging in the programs. A lot of adaptive designs are in use, and it requires still a lot of capacities to be built of people, and awareness and sensitization that this research is something also which requires investments. There are a lot of useful resources there, courses being developed. We at All India Institute of Medical Sciences are also currently building a course for program managers on implementation research. And somewhere in August or September, this course is going to get ready and will be rolled out. We are doing this, collaboratively with Johns Hopkins Institute as part of our, primary healthcare partnership project. But there are many resources out there for everyone who is attending this and who's going to be listening to this to take help and move, towards creating these research pieces also as part when we are delivering our interventions routinely, and we want to improve them so that the desired results can be achieved. And it's so relevant in the case of malaria elimination when we are heading towards the last mile efforts. We require more strengthening, more investments, and I think MERA is a step in that direction, and there are a lot of efforts happening in that direction too. So thank you.